Okay, I'm going to go over the urinary tract infections, what the workup and treatment is, basically empirical treatment specifically, and also I'm going to try to correlate everything to the case. So here's our urinary tract. Starts with the kidneys, ureter, bladder. We've got the prostate right here. We've got the urethra. And dang, they know how to draw these things to anatomical size. This is obviously a male because of where the prostate is located. In women, I think it's removed right after conception. So anything above the bladder is considered upper tract. Anything the bladder and below is considered lower tract. And so the common infections that you can get with these, well, with the upper tract, an infection of the kidney, that's pyelonephritis. An infection of the bladder is cystitis. Prostate is prostatitis. Urethra, urethritis. Depending on the presentation and the causative organism, and also just depending on which text you look at, sometimes prostatitis and urethritis are not considered urinary tract infections, and sometimes they are. Especially when urethritis is caused by an STI, it's not typically referred to as a urinary tract infection. When you're talking about urinary tract infections, there's a lot of definitions. I'm going to go through many of them because they have teachable points. So the first thing is there's a difference between bacteriuria, which is bacteria in the urine, and urinary tract infection. The first main thing is that bacteria can be either symptomatic or asymptomatic. So sometimes you can have bacteria in urine and you have no symptoms at all. The second thing is sometimes you can have an infection without bacteria actually showing up in the urine. This specifically can happen if you have one area of the kidney inflamed and the calyces, or the collecting area below that infection, is blocked off by some type of urolithiasis. Now, most of the time when you find bacteria, it's due to contamination of your specimen. In order to prevent contamination, there's special procedures that you have to follow when you collect urine. And the reliability of that urine specimen depends on the technique that was used. So you can actually do a suprapubic aspiration, that's the most reliable. A catheterization is the next most reliable, and then a voided specimen is the lowest in the reliability. A UTI, urinary tract infection, that's the inflammatory response to bacterial invasion. It's usually associated with, this is supposed to say not bacteria, but bacteria, autocorrect, or whatever it is. And so it's associated with bacteria and pyuria. Now this inflammatory response can be either in the upper or lower urinary tract. So a pyelonephritis and a cystitis, these are both, you can both collectively call these urinary tract infections. Or in layman's terms, kidney infection and bladder infection. And just as a side note, I think it's important to have layman's terms because we have to know how to communicate this stuff to a patient. A UTI can either be complicated or uncomplicated. So uncomplicated, the person that's infected is healthy, all of the anatomy is fine, and then there's a normal urinary tract. A complicated UTI, there's something either structurally or functionally wrong with the kidney, usually the kidney, but anywhere in the urinary tract. The host is immunocompromised, or the bacteria is highly virulent or resistant. So what do I mean by functional? There's a couple different things. So for example, you could have a reduced concentrating ability in the kidney. You could also have a neurological condition that prevents complete emptying. Then you can also have structural abnormalities, and these would include things like a calculi obstructing the flow of urine. It could also be an enlarged prostate, or you could have a site where urine is being trapped. So like, for example, here's my kidney, and here's the calyces that come in and drain into the bladder. So if you have something like a diverticulum, or if you have a spot in here where urine can just set and settle without being emptied down in here, you're at an increased risk for this is going to be a complicated UTI. And that's because bacteria can just kind of sit in here and reinfect after you flush. So you flush out antibiotics through here, and it flushes over this area where there's bacteria just sitting around in here waiting. As soon as the antibiotics are gone, they move back out and do their thing. Now, most of these definitions are useful when you're reading primary research on urinary tract infections, because they like to say, if you have a first infection, if you have an isolated infection, what are your risks, what's the epidemiology, this and that and the other. But there is also some important clinical stuff in these definitions as well. So if you have a first or isolated UTI, that's just like it sounds. It's the first UTI in a person who's never had one before, or it's very remote from a previous UTI, so that would be isolated. Unresolved and recurrent are two different things. Unresolved means that the infection didn't respond to therapy. Recurrent means that the infection was documented as going away, and then you get another infection. The reason this is important, because if it's unresolved, you're going to want to change up the therapy. You're going to want to change how you're treating the disease. If it's recurrent, even if it's the same bacteria, you can use the same treatment and it should go away again. Now then you have a third thing called persistence or relapse. So both of these terms are used interchangeably, and what it's saying is, like, so if you have a stone and the bacteria are living inside of that urinary stone, and you treat the bacteria, they go away, and then they reemerge from that stone because you're not getting any antibiotics to where they're at. This can also happen with the prostate. So the prostate can harbor bacteria. As soon as the treatment's over with, the bacteria will move out of the prostate into the rest of the body. And one way to diagnose this is you have to do a 4-part urinalysis. So you do the first part where you collect a few milliliters of urine, and then a second part where you collect a few more milliliters of urine, and then on a third part you have your prostate massaged, or you do something with it anyhow to the prostate while you're urinating, and then a fourth urine collection where you're not doing anything to the prostate. You've already done it, and then you just finish peeing, and that's the end of the stream. In the military, we'd have to get a urinalysis every year, or about every year, to see whether or not we were doing any kind of illegal drugs, illicit drugs. And sometimes they would do them just randomly. The entire command would have to go and do a urinalysis. And we called these Operation Golden Flow. Now I call this special prostate urinalysis Operation Golden Flow with chocolate on top. And the main reason why it's important to say whether a UTI is domiciliary or nosocomial is because the most common bacteria you get in each of those settings will be different, and so it will change your modality of treatment. So UTI is not acquired from a hospital or institution. These are UTIs acquired from a hospital or institution. So just keep that in mind. I promise this is the last set of definitions. So significant bacteria, this is important diagnostically, because whenever you have contaminated urine, so if you didn't clean the tip of your penis before urinating into the cup, and you had staph epidermidis on the tip, and you got it all in the cup, well, there's a certain amount of bacteria that can live per square millimeter, per square inch on your skin. There's a certain amount that can live in that certain area of the vaginal canal. And so significant bacteria is the number of bacteria in the urine that exceeds numbers usually caused by contamination of the skin, urethra, prepuce, or introitus. Now, a few sources said that number is 10 to the 5th bacteria per milliliter. And that's important because you can detect bacteria as low as 30,000 colony-forming units per milliliter. You can detect that in a microscope. The reason for that is because whenever you put a drop of urine onto the slide for a microscope, the amount of fluid in that drop is 1/30,000th of a milliliter. Any amount less than this requires culturing, really, to find it or to observe it. But you can get way more than this just from your urine just touching your skin. So just remember 10 to the 5th CFUs per milliliter. If you have less than that, you need to consider contamination. But one of the key things to look for in contamination is epithelial cells. If you have epithelial cells, then it indicates that the urine was in contact with epithelial cells, of course, which means contamination. Pyeluria, so this is basically means pus, or white, in other words, white blood cells. The presence of white blood cells in the urine. So it's really indicative of an infection that is causing an inflammatory response. In other words, a UTI. However, it can be seen without bacteria, and it's seen whenever you see pyeluria without bacteria, you want to think of three things. You want to think of tuberculosis, you want to think of stones, because stones can cause an inflammatory response, and you want to think of cancer. On the other hand, if you have bacteria without pyeluria, it's indicative of bacterial colonization without infection. Which brings up two more definitions, colonization and infection, but I'll let you look those up. Well, I'll just tell you. Colonization, presence of bacteria without signs of illness. Infection, presence of bacteria with clinical signs of illness. So you have colonization of bacteria in your GI tract normally, and in some small cases you can get colonization in your urinary tract without infection, but it's not very likely. Okay, I'm just going to say these last three are not used consistently in a lot of the sources I've looked at, but in Walsh's Urology 10th edition, a 4,000-page textbook on urology, so I think it's probably right. That's where I'm getting these definitions from that I'm giving to you. It defines it as a clinical syndrome. So cystitis, literally the etymology of it means inflammation of the bladder. But inflammation of the bladder, you don't really open up the bladder and look and see if it's inflamed. So it's defined as a clinical syndrome of dysuria, frequency, urgency, and occasionally suprapubic pain. In the same way, you don't cut open the kidney to see if it's inflamed. So pyelonephritis literally means pus and inflammation of the kidney. So a point I want to make is I didn't say anything about bacteria in those definitions, and that's because cystitis, for example, can be bacterial cystitis, or it can also be due to non-infections like interstitial cystitis or bladder carcinoma or calculi. Now, whenever you have this clinical syndrome of pyelonephritis, which typically in sources are going to vary on exactly which of these it includes, but chills, fever, and flank pain are the most commonly cited. And whenever you have these with both bacteria and pyeluria, it's very specific for an infection of the kidney. Now, chronic pyelonephritis, it's not a syndrome at all. It's a morphological diagnosis. So you're looking through radiology and other things, and you see a kidney that is shrunken or scarred. It's typically a post-infectious etiology, but it can also happen without an infection. So from those definitions, you should already have the main clinical presentation. And by the way, I think we should change the word urgency to urgent P. It's the same number of syllables, and it describes better what's actually happening. So the clinical presentation of an upper tract of a pyelonephritis are flank pain, fever and chills, malaise, pyeluria, bacteria, and sometimes nausea and vomiting. And there are several other non-specific findings that are sometimes, or you could say not rarely, but less commonly associated with pyelonephritis. Now, none of these things are diagnostic, so you want to raise, this is going to raise clinical suspicion. Another thing that should raise clinical suspicion is by looking at the specific gravity of the urinalysis. So let me explain this. A high specific gravity is usually associated with things before they get to the kidney. So if you have heart failure, if you have a renal artery stenosis, if you have extreme diarrhea or sweat causing dehydration, all of these things are going to reduce the filtration in the glomerulus and increase the specific gravity. Another thing to point out would be diabetes mellitus. This will increase the specific gravity. So all of these things are pre-renal. However, if you have a low specific gravity, this is typically from things that prevent the kidney from concentrating the urine. So you're looking at damage directly to the kidney. So low specific gravity is indicative, not diagnostic, but indicative of a kidney problem. And when you have that combined with other suspicions of an infection, you want to look and do radiologic imaging to see if it's pyelonephritis. Now, even the radiologic criteria for diagnosing a renal infection is flawed because you can have interstitial renal inflammation, you can have an immunologic or a congenital or even a chemical lesion. You can have other types of infection like granulomatous diseases, and you can even have a neoplasm, cancer, that all look radiologically like pyelonephritis. Your differential diagnosis, however, the most common things that you're going to have before you do imaging that can mimic all the symptoms are appendicitis, so the appendix, diverticulitis, and herpes zoster. I'm not even going to write those all out. I'll just put diverticulitis, herpes zoster. These are all pretty easy to rule out through other exams, and so if you've ruled those out, go ahead and treat the guy, the girl, whoever it is, and make sure you're mindful of other possibilities. Now, cystitis, we have typically frequency, urgency, dysuria, pyuria, bacteriuria, suprapubic pain, and occasionally you can get hematuria. Another thing that's indicative of all these things is a foul-smelling urine. So you might just ask your patient, what does your urine smell like? Which I think that's weird because that implies that they're sniffing their urine. You can be like, hey, I know you don't sniff your urine regularly, but this morning when you went pee, did it smell different? Now I'm going to point out one more thing. All of these symptoms of cystitis are usually also present in pyelonephritis. And it's not extremely uncommon to have a pyelonephritis and then it turns into a cystitis simultaneously. However, the typical natural history of the disease is that it travels upstream instead of downstream. So when would you get a kidney infection without a bladder infection happening first? That typically happens if you have sepsis or if you have a disease, an infection coming from other tissues. So the disease can move in from the blood or the surrounding tissue, and then it can go into the kidney, and then you'll have only a pyelonephritis. But typically you have the organisms moving up the other way. Now, before I go on to the next slide, I want to ask one question. Do we need to culture the bacteria? The answer is if you have a high clinical suspicion of a specific type or group of bacteria, and you are pretty confident that it is a urinary tract infection, you can treat it empirically. There was a study done in 1985 and again in 1986. There was some follow-up on that study, and it showed that it saves tons of money to treat these things empirically because, for first thing, UTIs, and this is according to Urology 10th edition, UTIs are the most common infection. Now, I don't know about you, I've had several sore throats, and I consider that an infection. I haven't had a single UTI, so I don't know if that information's right. Furthermore, I've had diarrhea, probably caused by an infection. Thankfully, it went away. I've had that several times in my life. Yeah, I'm not ashamed about it. I've had diarrhea before, but I've never had a UTI. So I don't know if that factoid is really a factoid. I'm just saying, according to Urology, 10th edition, a UTI is the most common form of infection. And so if you were to actually 100% verify the exact bacteria in every UTI, you'd be wasting money. You just treat it empirically. But remember, I said that you can have complicated and uncomplicated infections. If you have any indication that it is complicated, and sometimes it is, then you want to culture it while you're empirically treating. So what are the most common bacteria with cystitis? So in order to treat empirically, we got to know what's most common, right? So just remember that cystitis is pesky. And that'll tell you that it's Proteus, E. coli, Staph saprophyticus, Klebsiella, and Enterococcus are the most common. However, E. coli and Staph saprophyticus are by far the most common causes of cystitis. Now, I have a question for you. Why E. coli? The answer to that is because, and this is typically in women, the anus is so close to the vagina. You naturally have E. coli living in your gastrointestinal system. However, whenever it gets out of that gastrointestinal system through the anus, it can very easily be transferred through different things like wiping the wrong way. So it's like Tinder, you're supposed to swipe from front to back. This is the equivalent of swiping left. You push the bacteria away from the goodies. Now, unlike pyelonephritis, which often requires imaging, cystitis, you can diagnose it based on urinalysis and microscopic exam. And like I said, culture not typically cost effective. So what other things can look like cystitis? Well, vaginitis and STIs such as HSV, gonorrhea, chlamydia, trichomoniasis, yeast, and bacterial vaginosis, which isn't necessarily an STI, but it kind of can be. Now, I gave you the bacteria of cystitis. The bacteria of nephritis includes E. coli, Proteus, Klebsiella, Serratia, Enterobacter, Citrobacter, E. facialis, I'm not sure if I'm saying that right, Staph epidermidis, and Staph aureus. Now remember, there are several others. These are just the most common. For example, when I was looking over the urease positive bacteria, I noticed one called nocardia. Nocardia typically doesn't infect the urinary tract. When you do get infected, it's usually in an immunocompromised person, and it's usually through the lungs. However, somehow there's a paper written about how it disseminated from the lungs to the urinary tract. So it does happen. And your differential diagnosis for nephritis, I think I already went over this, appendicitis, diverticulitis, pancreatitis, herpes zoster, shingles. And all of these are going to have slightly different presentations, but you want to have them still in the front of your mind and rule them out because it's so difficult to diagnose pyelonephritis. I'm saying difficult like nobody ever does it. It's not really that difficult, but it's more complicated than just cystitis. Okay, the last thing before I go into empirical treatment, I'm going to talk about other infections that I haven't really classified well that are part of the urinary tract. So you have emphysematous pyelonephritis, which is still pyelonephritis, just different. You have infected hydronephrosis and pyonephrosis, perinephric abscesses, periurethral abscesses. So just like they sound, an abscess that is on the kidney, an abscess that's on the urethra. Infectious granulomatous nephritis, this is basically you get an infection of the urinary tract. At least this is how people think. No one knows for sure exactly how it happens. But you get an infection of the urinary tract, and the bacteria are not completely broken down, and they leave behind some of their lipid cell walls, and there could also be lipid from your own body's cholesterol and other sources of lipid. But these macrophages start ingesting that lipid. They become foamy macrophages. This can also be in other parts of the body, so it doesn't have to be in the kidney. It can spread around. Usually, Proteus and E. coli are implicated. Malakoplakia is usually in the immunosuppressed, and it's from foamy histocytes. So not foamy macrophages, but foamy histocytes. I'll be honest, I didn't take the time. I have no idea what a histocyte is. The etymology of it makes it sound like a tissue cell, which is kind of redundant. Bacteremia, just because the bacteria being in the blood has a high chance of being pushed into the kidney. Fournier's gangrene, not extremely common in the urinary tract, but it can happen just like everything else can happen. You can get renal Mycobacterium tuberculosis, for example, Pott's syndrome. And then finally, renal cell carcinoma. This is, of course, is non-infectious, but it presents like several of these other diseases. So renal cell carcinoma is most often misdiagnosed as infectious granulomatous nephritis. Let me say that one more time. Infectious granulomatous nephritis. That sounded better. So what do we want to do with empirical treatment? What kind of thinking should guide your decision? First of all, complicated versus uncomplicated. If it's uncomplicated, you're going to want to do empirical treatment to start with, but as soon as you know what the bacteria is, as soon as you know what it's susceptible to, you want to go ahead and start treating. And you want to use a non-empirical treatment. Another thing, and I don't have it written on here, but you're going to want to understand that serum concentrations of an antibiotic are not typically the same as urine concentrations of an antibiotic. And so what you're going to want to do is find an antibiotic that has high urine concentrations, regardless of what the serum concentrations are. And because you can find a good antibiotic that will work just fine on a urinary tract infection that you wouldn't have otherwise considered due to the minimum inhibitory dose if you only look at serum concentrations. So another thing is the drug spectrum. Exactly what bacteria will this drug kill, and do I think those bacteria are likely the cause of the infection? And so that leads into the next thing, which is probable pathogens. So probable pathogen and drug spectrum slightly different, because if you have a probable pathogen and then you have a next probable and the next probable and the next probable, so like the third or fourth one down, you want to try to get a drug that'll knock out at least the first 3 or 4 probable pathogens. Of course, does the patient have any known drug allergies? The other thing is you want to consider renal and hepatotoxicity, so other side effects, especially in those who have a complicated presentation. Now, the cost of medicine changes from one region to the next, from one state to the next, from one town to the next. And so you, when you're practicing, want to consider what's the local cost. Look at your cities, look at your Walmart's $4 list, look at the local prices and stuff. Then the last thing, which probably isn't considered very often, I just on experience, is whether or not you have favorable or unfavorable effects on the gastrointestinal and vaginal microbiota. Now I'm going to be honest with you. So far, I haven't watched any of the microbiota lectures, and the reason for that is I've read a lot of primary research in the field while I was an undergrad, and honestly, my conclusion is that most of the research is hokey. Like, I have a lot of questions to ask about it that the researchers are not answering in their paper. Now, I know it's important. I know I don't have the right bacteria in my GI tract. I start pooping a lot more, and it's a lot softer, and I don't like that feeling. I don't like hard poop either. That's odd. I just realized I don't like hard poop or soft poop. I just don't like poop. And so bottom line is I just won't take any of your crap. Now anyhow, I digress. How do we make all of this work? So let's talk about our case. In our case, we had something that was urease positive and nitrite positive. Nitrite positive is less specific than urease positive. So nitrite positive, tons of bacteria. Usually the gram-negative, so a lot of gram-negative bacteria are nitrite positive. However, on urease positive, we're given a mnemonic in first aid of the USMLE Step 1. That mnemonic is Chuck Norris hates punks. And so we have Cryptococcus, which is actually not a bacteria, it's a fungal infection. And then it's still an infection though, but it's just fungal. Then you have Helicobacter pylori, or H. pylori, Proteus, Ureaplasma, Nocardia, Klebsiella, Staphylococcus epidermidis, and Staphylococcus saprophyticus. Now, like I said earlier, it was also nitrite positive. I didn't check specifically, so let me just point out, Nocardia, Staph epidermidis, and Staph saprophyticus, these are all 3 gram-positives. The ureaplasma is a Mycobacteria samae, or it's related to Mycobacterium. The Cryptococcus is going to be a fungus, and it's not going to have a gram stain. Now, like I said, I'm just using reasoning here. These may be able to make nitrite, reduce nitrite. It's something called reductase is the enzyme that does it. Our bodies don't produce reductase, and so we don't reduce nitrate to nitrite, but a lot of gram-negatives do, and I don't know if these specific gram-positives do or not. So you'd want to check, but I'm just using reasoning here, and I would say that if we were treating empirically, we would want to treat something that could get Klebsiella, Proteus, and Helicobacter pylori. Now, I want you to know I did check Helicobacter pylori can cause urinary tract infection. I checked all of these to make sure they could, and all of these, and some of them in very, very rare cases, but all of these can and have been documented to cause a urinary tract infection. I don't think Koch's postulates were used, but the evidence pointed towards, yes, these were the causative organisms. But anyhow, we want to find something that can treat at least these 3 things, and if we can get all of these things with one medication and it's really cheap, then that's even better, especially if it's not nephrotoxic. Okay, I went ahead and highlighted in gray the ones that are really uncommon. So, Cryptococcus, Ureaplasma, and Nocardia, these are uncommon these are really uncommon, so I could find very few papers on it. Now, Ureaplasma may be an exception. I didn't look extremely hard on that, but it seemed from the little bit of researching that I did that it's pretty uncommon, pretty rare. Now, so at the top I've got the bacteria listed, and on the side I've got specific antimicrobial agents. I'm going to let you know right now I have 3 slides of these. I'm also going to let you know that on the gram negatives, so I got all of these except for the very last one, all of these antimicrobial agents I took from Urology 10th edition. They have a little chart that they used in there where they compared the spectrum of the various antibiotics and what it would kill. I did not reproduce that chart, but if the chart said that it could kill most gram negatives, I went ahead and put an X in all the gram negatives. So what I'm saying is this chart is just for illustration purposes only. I'm not 100% convinced that it's all reliable. I made it as reliable as I could in the amount of time that I had. But what I'm illustrating here, the illustrative purpose, is that let's take a look at either amoxicillin or ampicillin. We're missing a lot of possibilities. In fact, only a rare cause of urinary tract infection is really treated, so I definitely would not treat empirically with that medication. However, when we get down here, so we have a first-generation cephalosporin that can kick a lot of butt. We have a third-generation cephalosporin that kicks everything except for the stuff in gray. Now, on these things that are in gray, I honestly, so especially with ureaplasma and nocardia, I couldn't tell you for sure what the minimum inhibitory dose of these various antibiotics are, or whether or not the urine concentration reaches those minimum inhibitory doses. What I did not find was any literature that mentioned these being treated by several of these other antimicrobial agents, so I just left them unchecked. And so it's going to be very, very misleading with nocardia, especially because most of the time it's not a urinary tract disease, and so the type of treatment you would use for that would be something that has the right dose present within the plasma within the blood, not something that has the right dose within the urine. So the literature is going to be misleading on what you can use to treat this in a urinary tract. Aminoglycosides, but remember, these things are nephrotoxic and ototoxic, so if you can find something better, use it. So I would say that cephalosporin we looked at would probably be better. However, let's look at the treatment we actually use, this third generation fluoroquinolone, which is ciprofloxacin. It can hit everything that's not extremely unrare, and it will get the nocardia. It doesn't, I couldn't find whether or not ureaplasma. However, it doesn't have any effect on the fungus. With fungal infections, you want to use amphotericin B. Or with this specific fungal infection. Things that I noticed in looking at this, ketoconazole does not help at all, but amphotericin B does a really good job. Now, I pulled all of this information from a lot of different sources, but I leaned extremely heavily on the Campbell-Walsh Urology 10th edition. I encourage everybody to go, if you want to know more about this, go read chapter 10 of that massive book. It's like 120 pages, just that chapter. But if you want to know more, that's where you can know more. Also, if you want to know about urinalysis, the UA, I made a video on that. It's about 30 minutes long, so I'm not going to be adding it to this. I was going to put all of it together, but urinalysis is pretty extensive, and so I tried to make it exhaustive but still concise.